So the POUT trial was set up really to meet an unmet need. Prior to this, we had no data at all to support what we were doing. So there was no standard of care. We didn't know whether chemotherapy would work to reduce the risk of recurrence. Some people were giving that, some people were doing surveillance, and there was really an unmet need. And because this is a rare incidence tumor, it was felt that by the global community that doing a trial in this setting would be just too hard, because you would need to be able to recruit pretty much every patient that came in through the doors of lots of different hospitals. So this was an unmet need. And although upper urinary tract carcinoma is often lumped together with lower urinary tract carcinoma or bladder cancer, they're like distant cousins. They share similarities, but they're not the same disease entity, and they're not the same on a molecular level. And also they're not the same in the way prognostically. So stage for stage, locally advanced or muscle invasive upper tract cancers do worse than their lower tract counterparts. And we know that in advanced disease, in metastatic disease, that chemotherapy works. We've known that for 23 years since the original Van der Maas paper. So it made sense to look at doing a study. And because it's a low incidence tumor, it would have been impossible to do a study of the size that had overall survival as a primary endpoint. We'd have needed a study of 500 plus patients, and that would have required global participation. And at the time we were designing the study, because remember, this was an academic study with no sexy drugs, it was standard chemotherapy, cheap as chips. There was no real enthusiasm for the global community to get behind the study. We did try. We reached out to Canada, we reached out to American centres, we reached across Europe through one of the EAU GU groups at the time. They had a study that they were looking at called the Uranus study, which was a mismatch of neoadjuvant and adjuvant chemotherapy, and decided they wanted to support that rather than POUT. Interestingly, that study is still open to recruitment and has gone very quiet. So the reason POUT was an adjuvant study rather than neoadjuvant was because we asked clinicians across the UK, and we also asked patients, because obviously there are concerns about giving adjuvant treatment after a nephroureterectomy because the patient has a single kidney, and we know that there is a drop in GFR after nephroureterectomy. But it's still perfectly good enough to give, for most of them, cisplatin down to a GFR of 50. And in the patients that aren't fit enough for cisplatin, just from a GFR viewpoint, it's perfectly good enough to give carboplatin for the vast majority of patients. And the concern was that if you did a neoadjuvant study, then we don't always know that patient's pathology beforehand. We can make a best guess, but we don't know for certain. And because the pathology of earlier stage UTUC is so much better, it's a 95% disease-free survival for PTA or PT1 disease, then you're potentially going to overtreat a patient. And also, we know that even in the best hands, systemic therapy can come with toxicity, and sometimes that toxicity is life-threatening. So it was, oncologists were simple souls. We like to have a piece of paper that says this is definite cancer. And there are diagnostic challenges around upper tract disease in terms of getting an appropriate biopsy and being certain that this is locally advanced transitional cell carcinoma. And so we ran focus groups for patients. We put together 2 focus groups and put 2 different designs to them. And we also asked the same question to the uro-oncology community across the UK. We gave them 2 different options, neoadjuvant and adjuvant, and we also asked would they support a study. What we found was that both clinicians and patients were unanimously in favour of doing an adjuvant study, and that's why we set this up as an adjuvant trial from the outset, really. But the reason we chose disease-free survival at 3 years was we know that the relapse rate is high for these patients, particularly for those with T3 and T4 tumours. And this seemed a very, appropriate surrogate for overall survival. And it has been accepted in urothelial cancer as an appropriate end mark already. in terms of, you know, DFS at that time point. And for other reasons that I've already mentioned, you know, to do a study with overall survival as the main endpoint in a low incidence tumor needs global collaboration. And it would have taken years and years to do it just in the UK. What we did have was 75 centres across the UK who were open, of whom the vast majority recruited at least one patient. And the uro-oncology community, so that's the specialist nurses, the oncologists, the urologists, the research nurses, just got behind the study, because the original question came from urologists, because you'd sit in your MDT and they'd say, well, we've got somebody with high-grade pathology, locally advanced after their nephroureterectomy. Are you going to give them chemotherapy? And we go, I don't know. So that's where the original, you know, the unmet need came from. So overall survival was a secondary endpoint, and we would have loved to have been able to recruit the full number of patients to get the answer, the full answer to that. What happened was the study met its primary endpoint of disease-free survival in favor of chemotherapy, and it did that early. So we were looking for that initially at 3 years, but at the end of 2017, when the team met together, the Independent Data Monitoring Committee, they saw that we'd met the endpoint early, and we met it at 2 years in favor of chemotherapy. And so really at that point, it would have been unethical to have continued recruiting patients to the study when we knew that what the answer in terms of disease-free survival was. And we know in an adjuvant study, what you want to do is keep those patients cancer-free. You know, that's an endpoint that matters, that's clinically relevant to patients. And that's why we had to stop the study prematurely, not because of toxicity or lack of effect. It was actually the opposite. So we did get a really strong signal towards overall survival, and stronger than you might expect, given the number of patients that we would have been short to have answered that question definitively. But it was a strong signal towards overall survival of those 261 patients. The other question that's often asked, chemotherapy type, that was probably the most common question I got asked. And we've just, having published the final outcome data, we can see that the question around carboplatin or cisplatin has been strengthened even more. And so for patients whose GFR doesn't permit them to have cisplatin, so a GFR between 30 and 49, then they will get benefit from 4 cycles of adjuvant gemcitabine and carboplatin. And we could see that from the original data, and it's now been strengthened from the final follow-up data, which has just been published in the JCO 2 weeks ago.